Assalamu alaikum. Good afternoon and very warm welcome. I am Dr. Sadaf Mushtaq. I am Fellow of Pain Medicine and Anesthesia Consultant. Pleased to be working at National Hospital and Medical Center with Call Associates. So in next few minutes, we'll be talking about establishing a cancer pain center and integrating interdisciplinary approaches for comprehensive care. Ladies and gentlemen, please welcome our team. Our first member is Dr. Rabia Wali. She is consultant pediatric oncologist, currently working at Shaukat Khana Memorial Hospital and Research Center. Next, we have Professor Hafiz Muhammad Asim. Professor Asim is the Dean at Ghurki College of Health Sciences, Ghurki Trust Teaching Hospital, and he is also consultant at IMC and Surgimed Hospital, Lahore. Next, we have Dr. Ateeq-ur-Rehamn Ghafoor. He is consultant pain specialist at Evercare Hospital and Saleem Memorial Hospital with very vast background and expertise in cancer pain management from Shaukat Khana Memorial Hospital. We also have Dr. Taskheer Abbas with us. He is a radiation oncologist and currently practicing at Saleem Memorial Hospital, Lahore. Next, we have Ms. Nasira Hayat. She is a clinical psychologist currently practicing at Shaukat Khana Memorial Hospital. And our last and the most famous person, Dr. Abbas. He needs no introduction. He has a vast experience of managing pain, and he's currently practicing in Karachi. So I welcome you all. So cancer pain is a crucial public health concern that significantly impairs the physical, psychological, and social operating of those who actually experience it. And cancer pain is not a simple pain, it's a complex pain. As per IARC, that is International Agency for Research on Cancer, number of cancer reported from Pakistan in 2022, they were 186,000, and these are only the reported cases. It has also been estimated that by 2050, number of these new cases, they will increase up to this level. So my first question is from Dr. Ateeq. Sir, are we ready to handle and take care of these patients?
So thank you, Sadaf. As we all know, like the cancer incidence is increasing and there is increased survival as well. And there's a young population as well who's getting cancer and being survived and living for longer years with the problems that's after the cancer treatment we see in the hospitals. But are we ready, talking like in a very local context? Dr. Ellen has quoted a local paper yesterday here from Aga Khan about the pain services in the tertiary care hospitals in Pakistan. There is a survey from Aga Khan, and that has shown the lack of basic pain services in more than 40% of the Pakistani hospitals. And if you talk about the Lahore, so if you starting from the Mew Hospital, the Gangaram Hospital, the Jinnah Hospital, they're all really big hospital, more than 600 bedded. So there is no real pain services in these setups. And it's only the private setups that has a part of the pain services. So I think so we are talking about the Pakistan, so we really lack the basic pain services coming up to the speciality or the subspecialty area like the orofacial pain or CRPS pain clinics, back clinics. That's a long journey yet.
Thank you, sir. So ISP defined integrative pain care as temporarily coordinated, mechanism-guided, individualized, evidence-based integration of multiple pain treatments. So my next question is from Dr. Abbas. Sir, how do you see how we can incorporate these in our cancer patient pains?
First of all, the most important I think the ultimate thing is to have a holistic approach. There has to be a team. The first of all thing is that it decreases errors significantly. I still remember at Cornell, an actress, Siri Devi, her mother got operated, and the resident put the brain cancer or brain tumor MRI on the other side, and she was operated on the wrong side, and she died. Now, besides checking patients before procedure for if it's right side or the left side, my even assistant remind me which side it is. So, you know, these little things can make a large difference. Well, injections are not going to work if they are done on the other side. They may not work. But, you know, sometimes it can have a disastrous effect. At the same time, the holistic approach, you know, you're not treating just one part of patients, but you're treating the whole patients. It also increases the interdisciplinary and, you know, the multimodal thing. It also decreases the problem solving. I still remember I was giving a lecture in Gujranwala to general physicians, family physicians. And a family physician told me that giving tramadol or opioids on empty stomach may decrease nausea, side effect. I always used to give them after meals. So even those things, if you're ready to learn, and from different specialties, from different doctors, it can provide a lot of information. It can also decrease cost because sometimes you do tests and MRIs and stuff, and they're not needed. But if you discuss with a colleague, for example, you know, an oncologist, that maybe I should get this done, MRI, maybe the tumor has spread or this and that, and he'll tell you, no, there's no signs and stuff, and it may it will decrease the cost a lot. Patient satisfaction increases a lot. In my clinic, I usually, if there's a complicated case, I call my GI colleague whom I have good understanding, or my neurologist or orthopedic surgeon, and give an input. If a neurologist is like next door, I'll just take the MRI and show it to them. At the same time, the doctors come out from their professional silos. You know, some of them think that, you know, they know everything. And that's very, very prudent to train our trainees that, you know, you need to ask no matter how senior you are or no matter how much you learn. So it provides, you know, a lot of information not only to you, but also these people who are going to be taking care of us, I think, and that's why I respect my juniors a lot. It's selfish, but I do it.
Thank you, sir.
Thank you.
Thank
I'm
you.
just
We'll
too
come
long.
back to you.
Yes. Okay.
Yeah.
Thank you.
Okay, sir. So when we talk about establishing a cancer pain management clinic, my next question is from Dr. Ateeq. Sir, can you please elaborate and describe what are the important common professional composition?
So I would refer here again the yesterday talk by the Dr. Mary Cordosa. So I think so the most important thing when we talk about the cancer pain is interdisciplinary approach, like taking every component into the account there. So whenever we talk about the different components, the biopsychosocial model, for me, like it's the best example is the cancer pain there. So whenever the cancer comes to somebody's mind, the next thing comes up is the pain there. And we all know like the pain does have the component that can't be counted in the physical or in terms of the organology. So the concept that we all know, like the biopsychosocial model, or in terms of the cancer pain, we talk about the total pain, or in palliative care terminology, the total suffering. And also this component is known as opioid resistant or the pharmacotherapy resistant pain component. And what is actually this component? So this component addresses the patient's psychology, his fears, beliefs, depression, and then his social problems related to the pain, like the fear that he's going to lose the job, and he's going to lose the social status there. And also the very, very important thing, like the biopsychosocial model don't talk about the spirituality there. Like you have cancer and you're young, like, and you're thinking like, why the God has done this to me? And you start talking about your fate there. Like, so I think so the important component, other than the managing the organic component of the pain, addressing these areas, psychology, sociology, their spirituality, that's really, really important.
Thank you, sir. Now, my next question is from Dr. Rabia Wali. Dr. Rabia, being an oncologist, how do you face these challenges while you are dealing with your patients, and how do you face these challenges while incorporating, besides your management, incorporating all these integrated pain care?
So I think as a pediatric oncologist, being advocates for children, the thing with the cancer pain is that you don't only take care of the cancer pain which the child goes through. You actually have to take care of the parents also, because once the child is crying because of the pain, the anguish that is there, you have to make sure that you're taking care of the parents and the families who are there. Okay, and I think the word cancer in itself is like a death sentence for so many patients, and they sometimes refuse to talk about it. Oh, so cancer pain is just not the pain that they have because of the disease itself, that is because of the chemotherapy which you give, the mucositis that you have. I think sometimes in most of the patients, it's the procedural pain also that you have to deal with, because they're going to get multiple intrathecal chemotherapies, especially in leukemia patients, because of the surgery, because of the radiotherapy. So the challenges, I mean, I work in a center where we have the facilities, we have got the psychotherapist, we have got the play therapist. So you need to involve the complementary medicine in addition to the pharmacological medication as a part of improving pain in these cancer children. Because when you have your play therapist, the art therapy that you have, the different types of massage therapy, because this is really coming up. And I think the challenges which we usually face in such situations is the availability of expertise, right? And then it's a financial burden on the families also, plus on the institutions. Because sometimes we barely have enough expertise or doctors or oncologists to look after the patients. And I think one of the other thing is that what we lack is the space also, sometimes the challenges which we feel, because you need to have a really quiet room, a very colorful room, if you're talking from the pediatric oncologist perspective. And I think sometimes we have time constraints also, because as an oncologist, you have to see so many patients that for such cancer pain where you have your multidisciplinary, you have got all the teams involved, like the other esteemed speakers mentioned, you really need to have good 1 or 2 hours to sit and talk with them. And it's the communication. I mean, I know we do have communication skills, but I think it's the time sometimes which can be quite challenging to find and treat.
This is the time where it comes the importance or the real role play of a clinical psychologist here.
Yeah.
So my next question is from Ms. Nasira Hayat. Ma'am, can you please throw some light on how we can educate the patient to come and seek this psychological support, and how we can help them in overcoming these barriers?
Thank you so much. As my colleagues discussed about, hello?
Yes.
As my colleagues discussed earlier about the biopsychosocial model and the family support, there are different ways you can help the patient. Firstly, you need to assess the patient first, the background he or she is coming from. Are there any hurdles, barrier, obstacles? And then you need to assess the understanding level in our culture, because majority patient we see in Shah Khanam, they are coming from the background where we go into their level and we do describe and counsel the patient according to their insight level. So firstly, you need to assess the education, the understanding level, and secondly, the education material according to their needs will be more helpful, like brochures and the written material, and then videos will be more helpful, and then one-to-one communication and one-to-one counseling session where the doctor discuss about their experiences, about the pain management and the medication experience. And then also he or she can talk about the fears, anxieties, and the frustration, and they have appropriate social and family support. And thirdly, the workshops, seminars, and sports groups are more helpful, where they can talk about their coping mechanisms and discuss with the other patients. This will help them to motivate and provide them positive self-esteem. And secondly, important in our culture to talk about the myths and miscommunication about the pain management, which is very important. Usually patient don't understand the procedure, and during the treatment what level and what intensity of pain they are going to face. And most importantly, to talk about the non-pharmacological techniques like the physiotherapy and psychology, where they need to, consult a psychologist. Again, there is a stigma and taboo in our society where people, there's a psychology, they just see this is a counseling. This is more than counseling because this is related to the behavior, interactions, society, and the families as well. So need to involve the family and the empathetic counseling where you listen the patient very patiently and then acknowledge their feelings, fears, and frustrations.
May I just ask one thing? Dr. Sarah, do you have any like patient support group or family support group that they can sit together and some psychologists can guide them? Because I think that makes a big difference.
Yes, we have different types of sports groups. We're running stoma support groups. Then we have breast cancer support groups for the female and male patients. Then we have palliative support groups. And then we have pediatric cancer patients and their families for the newly diagnosed cancer patient and for the palliative care cancer patients as well.
Great, that's great.
Nasir, there's a lot here you have spoken about, like you need to communicate with the patient. So in context of our culture, like the people are very shy away, like to communicate and open up, like. So how do you manage that, like sitting in a cancer setup?
I think firstly you need to build rapport with your patient. As I discussed earlier, you need to understand where he is coming from, relate to the patient and their families. When you have active listening, when you give them time to express their feelings and frustration, definitely they will come in terms where they can discuss their feelings and related to anxieties and fears and pain.
Thank you, ma'am. Now let's have our reviews from Professor Asim. Sir, what is the role of a physiotherapy or physiotherapist in incorporating integrative pain care, especially in cancer patients?
Bismillahirrahmanirrahim. Thank you so much, Dr. Sabah. Physical therapy and rehabilitation is the most ignoring part of the any management, especially in the pain clinics and especially in cancer pain management patient, because most of the patients they have the mobility limitations. After all, after the pain control, what we need to improve the mobility status, functional mobility status. It is only possible after the physical therapy. So I think we should have a multidisciplinary teams in which the physical therapy and rehabilitation specialists should be a part of this team. The second one, if the pain is controlled, then what we expect to improve the functional mobility status. So it is a job of a therapist, and most of the patients they have limitation in the functional mobility, and especially the ADLs and IADLs. So we have to develop these such a teams that they must have such a physical therapist and rehabilitation specialist. That's my point.
What are the actual challenges that you face while you are actually working in the practical field and in your clinical practice?
Actually, the awareness, the one important thing. Most of the consultants, they are working the best. They are controlling the pain very well. But the outcome is only a mobility status and the functional mobility. And how could we can improve this? It's just because of the, we can improve by the physical therapy and rehabilitation. So that's the main important thing. If you are controlling the pain, then you can improve the the patient's ability by the physical therapy and rehabilitation.
Just one thing, how can, have you tried to create awareness among doctors who know which patients to refer and what not? Because that's important. If you don't know...
I'm sorry, sir. In every presentation, I saw the word physiotherapy, but I would never seen there in a team there is a therapist. You know, the difference between the education model and actual practical model is different, right? we should have a physical therapist in all over the team, right? Then we can improve if the physical, अब अगर physical therapist किसी team में काम करता है तो वो उसकी outcome of the patient जो है वो उसी की mark होगा, उसी team का. The objective of any patient defined by the captain who is managing the pain. और वो objective जब define करता है तो rehabilitation उसी के मुताबिक है, whether it is a palliative, rehabilitative या restorative है, तो वो depend करता है कुछ पे. जब outcome total depend कर रहा है उस पे, तो उसको हर टीम को अपने साथ एक physical therapist को ज़रूर होना चाहिए. That's my point.
ये मगर ताली एक हाथ से नहीं बजती, फिजियोथेरेपी वाले भी दूर दूर रहते हैं.
उसकी वजह है सर, उसकी वजह है, उसकी 2-3 वजूहात है कि एक तो हमारे यहाँ जो एजुकेशन मॉडल है उसने इस तरह की डेवलप नहीं कर सके. ये मैं तो अतीक साहब का स्पेशली थैंक्स करता हूँ कि इन्होंने हमें अपनी टीम में इनवाइट तो किया ना. तो ये एक तरीका होता है कि जब आप इनवाइट करते हैं एक दूसरे के साथ तो फिर ये चलता है. इट्स वंडरफुल. ये पहली दफ़ा ऐसा हो रहा है कि पैनल सेक्शंस के अंदर किसी को अंदर ये इग्नोरिंग पार्ट है. मैं ये इसे हकीकत एक्सेप्ट कर लेनी चाहिए. इट्स कि फिज़िकल थेरेपी से आप अपनी ही पेशेंट की मैनेजमेंट को अपनी आउटकम को उसको इम्प्रूव कर सकते हैं. If you can improve.
So I think from my experience with pediatrics is that because the parents are so heavily invested in the children, so you can even teach the parents, and they because they know they're doing something for the child, they will be like keenly interested in doing that. I mean, if you have issues with hiring or having lots of physiotherapists in your team, because they are really important part.
But
of
also
the
we are in our professional silos, you know we can do. Most of the time I've seen this, involving other specialties is done by very few doctors, like Dr. Ateeq and other doctors. But other doctors, they usually don't like to refer to a psychotherapist or a physiotherapist. But also there's a small part, tariq haath se nahi bachti, from physiotherapy department also. They need to like communicate and come forward and make a team, and wo bhi achhi tarah mile, to then it's going to be a better way out, I think.
Okay, so we all are on one consensus that we need to treat the pain, and besides we are treating the pain, we should work on improving the functional disability of the patient, and that can be done by referring and involving a patient to a physiotherapist, right? So my next question is from Dr. Taskheer. Sir, being a radiation oncologist, can you please guide us about some current radiological treatment options?
Thank you, Dr. Sadaf. So radiotherapy is, as you know, essential component of pain management in patients who have advanced cancer. It's one of the most rewarding, I would say, intervention for a radiation oncologist because the results are so good. Patients who have bone metastases or the primary tumor, which is fungating or invading adjacent structures, if you do radiotherapy on these patients, about 70 to 75% patients will respond, and about 1/3 of the patients will have complete response to the pain, and 2/3 some sort of partial response. We in our arsenal have multiple things. The most common is the external beam radiotherapy, the EBRT, which can be employed in single fraction or 5 or 30. Usually these are the most commonly used fractionation schedules depending upon the patient performance status and condition. And then you have radiopharmaceuticals like strontium and radium. And there is another evolving paradigm in the field of radiotherapy, which is SRS and SPRT. In the recent trials, it have shown promising results in the control of pain. As we are discussing an integrated pain care management, I think radiation oncology plays a very important role over here.
Okay. So what are the challenges that you face while especially working in a private and public sector hospital?
So in our country, the most, I think, the important component or the most important challenge is the availability of radiotherapy centers, basically. So we have only Shaukat Khanum on Mole, Cancer Care, CMH, and Saleem Memorial in Lahore. which are, I think, way less for the patients we are having and we have to treat. Sometimes in the public sector, patients have to wait for, like 3 weeks or 4 weeks to get an appointment for the radiotherapy. So we need to build and have more radiotherapy centers. That is one thing which is essential. And the other one is the cost issues, as you know, because inherently to set up these facilities would require a large amount of resources and money and expertise. And consequently, this raises the cost of the treatment over here. So these are the challenges we face mostly.
So do you think in near future, are we gonna overcome these challenges, or do you have some suggestions?
I hope so. I think one solution is to build a more radiotherapy centers in the public center hospitals, in the tertiary care hospital. I think everywhere we have a radiation bunkers, but we don't have a functioning LINAC over there. And then what we're doing over here is like educating people, let them know, and formulate a comprehensive cancer care pain, I would say, a center in which people can collaborate and refer patients early so they can get treatments for this debilitating pain.
So establishing more collaboration will be more helpful.
Yeah,
right?
yeah, I totally
So
agree.
the scarcity of the drugs and the limited resources and restrictive regulation of the controlled substance in our part of the world especially, it's a reality. Okay. So my next question is from Dr. Abbas, how to handle it outside Shaukat Khana.
Outside Shaukat Khana. Okay. So, I mean, opioids, they are essential part for the cancer patients and for other pains you can have. I think the problem is with the regulatory authorities and with the government understanding the need for it. So it's difficult to get morphine within the hospitals, but if you go outside in the street, it is very easy to get it. Okay. So I can speak from my personal experience as a part of the Pakistan Society of Pediatric Oncology. I think what the societies can do is, so I know this can become a little political and a bit troublesome, but when you have your meeting, so what we have done in the last 2 to 3 years is that we usually end up having an inauguration session, which is different from your scientific session. So if we're having a meeting on a Friday or a Saturday, so Thursday evening will be our inauguration, where we have these government officials come in, and then you can highlight the importance of these drugs. So the Pakistan Society has also worked with WHO, and we have now made the government realize that there are certain essential chemotherapy drugs that you need. And the other thing which you can do is then when you have your societal meetings like these conferences, so the president or if you have international speakers, you can actually write to the government officials highlighting why you need these medications. Because getting a legalization of these documents and availability to both the government as well as private sector, you need to have the government involved. It cannot be less laid on individuals doing that. And it's going to be try, and we have to try, because without the opioids, it's going to become very difficult treating these patients. Yes, Dr.
Dr.
Ateeq.
Rabia, I think so. I won't shy away to claim like I am the best person to answer this question. So I do have the experience of West, and I have worked in a place that's like an island in this country. We're talking about Shaukat Khana. And then I am working in the private setup now. So the opioids, I can talk like Roberts about this, problems here in this country. So there is a term when we talk about the opioids, like the fear of opioids. When you're reading about the opioids, like the side effects and the management and everything, medical students knows about this term, like the fear of opioid. But Pakistan is the perfect place to understand this term. So government is feared of opioids, physicians are feared of opioids, administration is feared of opioids, but it's available like illegally, like on the streets. But for having it for the patients, it's a lot of struggle you need. So if you talk about a hospital who really want to have the opioids, they really need to have a strong will and a patience. And they need to have a dedicated team who keep on working with the government. There are about 4 ministries you really need to work to get the allocated quota. And even in the very good institutions in Pakistan, like Shaukat Khana, during a year time, there will be few months they're out of opioids.
Yes.
And it doesn't end here like the misery. I mean, we just have the oral morphine if you talk about the variety of opioids here. So there is no, I mean, fentanyl patches, no oxynome, oxycodone. And if somebody is not responding to morphine or is intolerant to morphine, you have no option. And if you go like to the local literature search here, see the newspapers, it's full of stories like the experts and the local doctors and like me, journalists have written stories about. And coming back to the Shaukat Khanum, means it's a cancer setup. The reason the Imran Khan built this hospital was the pain. He said I was the one of the influential person among the society, and my mother pain was not being controlled, and I was unable to manage the medications for her. So I am here for 8 years in Pakistan, no, like, but it's still the same story, still the same story. Nothing has really changed. No government has really worked for it. No organization, including us, hasn't worked for it. And in every meeting, we keep on talking about it, but unfortunately, no practical steps.
So interestingly, Dr. Ateeq, you talked about the fears of addiction, but I have found patients, they don't have the fear of addiction because when they're in so much of pain and there's a medicine for it, they're ready to take it. So it's the fear of addiction which I think comes from, except from the patient, everyone else.
So I have seen oncologists suggesting to the patients that they can use, street drugs to control their pain. That's the real issue, because as Dr. Ateeq has told us, that they are not available and patients are in misery, and out of frustration, some oncologists tell people to go and use street drugs.
Yes, I have experienced that, especially when they're on palliative care, because when they're on palliative care, the only thing that you need to get on top of is the pain.
I just want to add something.
Yes, sir.
With the scarcity of opioids, I've started using pregabalin higher doses. In some patients, or even 50 milligrams give them dizziness and stuff. But in some patients, 200 milligrams 3 times a day alleviates their pain, and they don't have any dizziness or oversleepiness. Yes, there is dizziness, side effect, and everything. But pregabalin is also approved 50 milligram in Europe for anxiety disorders. At the same time, it does not cause any nausea. It increases appetite. It takes care of anxiety, no constipation. So you may consider as a polymodal analgesia using pregabalin, sometimes duloxetine. And some people, if I know I shouldn't be doing that, but if they pregabalin 50 milligram or 25 milligram is a lot, I tell them to open the capsule and take half of it. And that kills their pain and, helps out with their pain 20%, 30%, 80%, and they don't get the side effects. Some people, I give them tramadol, like very low dose. And some, everybody's different. I'm sure you know that. Duloxetine has not as much promising results, and gabapentin causes more sleepiness, but in some people, gabapentin has helped a lot. So using these until, something comes up, and we should keep trying to get the real medicine. But these are some of the options. Dr. Gaurav said a very nice thing about oral ketamine. So we can, use a little bit of oral ketamine, a little bit of pregabalin, idhar se thoda liya, udhar se thoda liya, maybe until we get something. But yes, we cannot, one of our surgeons in one of the public hospitals in Karachi, he just tells patient, bazaar se jao, afeem lo, thodi si khao, agar fayda nahi hota, thodi aur khao. When the patient is tossing and turning and screaming and crying in pain, the whole family is suffering like you can never imagine. I'm sure you have seen it day in and day out. So, we have to help them out any way possible. So that's what I'm using these days. Thank you.
Thank you very much, sir. Yes, sir. So you can come over the mic and we can communicate then. Inko mic please. So we have talked about patient's pain, patient psychological support, and other issues. Now my last question is from Ms. Nasira Hayat. Ma'am, what about the care of caretakers? like how we can provide the emotional support to those who are actually seeing their patients actually dying. So how we can handle them, and what do you have to offer them?
So as you said, the caretaker have very important role. And in our culture, sometimes there are two sides of coin. When the caregiver said a doctor doesn't have a time, he has very limited communication, he's in a hurry, jaldi mein rehte hain, jaldi mein chale jate hain. And on the other hand, when I listened the doctor, he said like family is very apprehensive, the caregiver is very anxious, he's very distressed. And here is the point where they need to understand the background. The patient is suffering pain and he's going to die. There are a lot of factors. There are frustrations, anxieties, and fear. So we need to give time to the caregiver, encourage them, reassure them, support them, and also tell them to take breaks whenever he or she is in. Maybe it will help them to regain their energies as well.
Now we'll take questions from the audience. Yes, please.
I'm Professor Jordan. I'm representing the public sector hospital. In this all discussion, one important aspect was missing. That was the establishing a pain clinic in a public sector hospital. All of you are sitting here, either they belong to an autonomous body institution or a private institution. So let me talk about a bit about the public sector hospitals. If we talk about Lahore, we have 6 to 7 major hospitals, which are carrying more than 1,000 beds, and on an average, 30,000 surgeries are conducted in each hospital. I'm not sure about how many cancer surgeries are conducted. I just know about my hospital. We have 2 dedicated lists, which are just confined for the cancer patients. Now, if you talk about establishing a pain clinic in a public sector hospital, it comes with a lot of hassle and lot of troubles. Those who are working in public sector hospitals, they know what I'm talking about. What are the logistical issues? What are the issues which you have to have when you talk about establishing a pain clinic? You need a place where you can see the patients, then you need equipment, then you need drugs, then you need to have integrated approach, either with the help of a physiotherapy department or a clinical psychologist. And on top of that, what about the personnel? Who is going to conduct that pain clinic? So this component, I would like to highlight this esteemed panel that they should guide us how to establish a clinic. Like I know that there is in LGH we are conducting a pain clinic, and we just learned it with we are not properly qualified to do the procedures, but we are just somehow we are managing it. Similarly, I know about Fatma Jinnah, where Dr. Liaquat is conducting the pain clinic, but these are not established pain clinic. So I would suggest STSP, the office bearer, that they should talk the health department that actually it is the need of the day that these type of institutions should be established in the public sector hospitals. The trained personnel should be posted there. They should create certain seat for the pain specialist. And then, and last of all, it is going to be a big service, because when you're going to train people, they'll spread out, and obviously we can expand the services. Thank you very much.
You're absolutely right, but at the same time, you know, our society and our government takes years for everything. You guys are doing, you know, a jihad with the limited resources and stuff. I think the society at this time, what we can do, if Dr. Ateeq and Brigadier Kiani,
that is a very pertinent issue Dr. Jawdat has talked about. But a little bit of it, the challenge during my own presentation in the inaugural session, we discussed it, I just highlighted is that we now have a lot of, quite a few, we should not say a lot of, but quite a few well-established pain centers, even which are now accredited by the College of Physicians and Surgeons for training. but only out of those about 14 centers, only one center, which is the Nasira Medical College, that is the public sector. Now the second one is upcoming in Holy Family, and they are going to inaugurate Holy Family Rawalpindi. They are going to inaugurate on 25th of this month, and they have already invited us to join that inaugural session. That pain center will be called as Saleem's. This may be a secret for them, but just let me disclose it, that is going to be called as Saleem's Pain Center or Play. Because over there, the clinic, that pain clinic was started by Brigadier Saleem after getting retired from Army. This, this is one. Yes, it should be there. But the public sector has to be sensitized. Public sector, hospital, their administrators, and talking about the job creation, again, it should be done, and we have to work. We should be working on that. And in our own way, bit by bit, we have to have more clinicians, more pain physicians. So the CPSP, FCPS pain medicine is actually the production unit which is producing now good quality pain physicians, and those pain physicians are our assets for the next few years. They are inshallah going to establish more and more such centers, and we prefer they should be in the public sector rather than the private. For the public, to sensitize the public sector people and the administrators, that is a challenge. We have to sensitize them. Sarab.
So the question that was asked, so what's the bare minimum you can have while working in a public sector? So I will speak from the experience of my colleagues from Children's Hospital, the Pediatric Oncology Department. They initially had lots of issues doing multidisciplinary meetings for their renal tumors and for their hepatoblastomas. And I think to begin with, it was a lot of personal effort which you did, that you went out to the different departments, talked to their heads and doctors. So yes, you need the sensitization of the administration, but it will have to start from the personal level. And it took a long time, but they are now able to do these MDTs. So if you're working in a Mayo Hospital or you're working in Jinnah Hospital, you really need to identify. So first of all, you need to take ownership. So as an oncologist, we take ownership of our patients, and then we have this umbrella where we involve all the other disciplinary teams. So it will have to be one person of that specific department taking ownership, and then you need to go out and identify personnel from within your hospital who are interested in this, and then you start to meet them over a cup of tea, maybe do dinners or something like this. It's going to be a lot of personal things which you do, and in the end it does help, because I know colleagues from Aga Khan Hospital and I know colleagues from Children's Hospital, or both private and public sectors, where you have to do these personal efforts and you do it for the sake of your patients, and it does pay off. But it's a lot of hard work and lots of persistence that you have to do.
So as healthcare is now a mainly provincial issue, and our provincial headquarters is in Lahore, Khalid Bashir Saab is the fit person.
Let's have
the right
reviews
person
from
to be
Professor Dr. Khalid
responding.
Bashir.
Thank you. I do not, so I agree with Dr. Kiani and Dr. Joseph that there should be a pain clinic in every hospital, but nobody stops us to provide post-op pain relief. Nobody stops us to provide obstetric pain relief. To provide post-op pain relief or acute pain service is our duty, which we are not doing. I have been working in teaching hospital for 34 years. And it is only, and I'm going to give the example of Brigadier Saleem. There was no pain clinic. He studied on his own. Kiani studied in his own. Jalanda studied in his own. I studied pain service in my own. So we have to start pain services to show people that we can do something. Pain clinic established, it is very difficult to establish a pain clinic. You need so many services. You need extra time. So acute pain service is our duty, which we should provide, and it will automatically will lead to establishment of a pain center.
So establishing acute pain services will create awareness.
Now, coming back to about the pain, the cancer pain, because this is a cancer pain session, and we have discussed in details. Let me share my own experience, my personal experience about problem. My mother had CA esophagus. She was operated upon, and she lived a good life, good quality of life, 3 years after surgery. And after that, she developed mets in the liver. And then at that time, I was posted to Bahawalpur. I was not here in Rawalpindi. And every 3 months, or maybe earlier, 1 month, 2 months, 3 months, I had to rush from Bahawalpur. Mujhe dard ho raha, I'm in pain. And
Yes, sir. I am Dr. Saleh from Nawab Shah city in the center of Sindh province and education and health city. Just one clarification. We have a public sector pain management center, and that was also inaugurated by Brigadier Saleem Saab. Initially it was a clinic in year 2008. Thereafter in 2014 it became a full-fledged center wherein we have all the 6 working days OPD as well as procedures, and we have all the necessary equipment as well as and Brigadier Gyani Sahab have visited there 5-6 times, and he was also the person who visited and is also accredited. So we have FCPS pain medicine in our center. Beauty of this is that कि हम उसमें पूरा हफ्ता OPD भी करते हैं और प्रोसीजर्स भी तकरीबन डेली 1-2 होते हैं. उसके अलावा पेशेंट को मेडिकेशंस भी पूरे हफ्ते की दे दें, उसके साथ 1 रुपया भी उसका खर्च नहीं होता. Not a single penny is expended. It's with the help of our Sindh government and philanthropy, and every intervention is provided free of cost in public sector hospital, People's University of Medical Health Sciences.
Correction, ji. Yeah, this is the second public sector hospital, and I know very well because how it started and how it was again. It's a very well established, mashallah. I was talking about the patient's problem, cancer pain, problem of the patient, problem of the relatives. I've suffered, I've been first-hand knowledge. So that's why I'm now very empathetic to all the relatives of the patients also. Now the problem was pain, and there was nobody to give a celiac plexus block. So the best opioids that we had at that time, we still have almost the same. We have opioids. We should not say that we don't have any opioid. The best opioids we have, which are over-the-counter opioids, which are not the control is not to that level. We have nalbuphine, which is very good. It can give an IV. We do not have oral opioids. In oral opioids, the best is tapentadol. Tapentadol. Now, the story of tapentadol is again that they have marketed it, they have got it approved from the DRAP as just for acute pain management. So not for chronic pain, not for cancer pain management even. They are promoting it, marketing ki just isko acute pain mein aap istemal kar le. So which is tapentadol. Tramadol ki story ye hai कि tramadol को एक stage पे probably it was WHO move, or they said that tramadol should not be over the counter because it's not that safe a drug. It has other problems also. So then usko to stop that for this region, for our own region, there was a discussion and then a survey, and that survey was published. Dr. Ghafoor, myself, it was initiated in Malaysia and the whole Southeast Asian region. We strongly recommended that it should not be a controlled drug, because if it becomes a controlled drug, we do not have any other opioid available to us. So about the strong opioids, there are reservations in the government. And when I was in the army, so I went to this anti-narcotic force, ke jo us waqt General Sahab the na. I went to him, no problem, you just tell us. But what sort of opioids do you want? Now he wanted to offer all sort of opioid for the army. He just, while I was sitting there, he talked to our Surgeon General. One of your doctors is saying that you don't have these drugs. We can provide you whatever you want. Now, ANF is one factor which is controlling the drug. DRAP is another factor, and maybe few other things which we have to satisfy all of them. We have to get their permissions. And then again, the issue is, the issue is of quota. Then your hospital quota is approved. For hospitals, they are allowing it, fentanyl and other medicine. The quota is allowed for, you say that you can handle it, but you have to document it. You have to keep all the documents. That's the responsibility of the hospital and the department, and then you have to show it also. So you say that I need 1,000 injections for this whole year. Now, once you start using those 1,000 on the patients, your demand increases. Initially, there was no lesser demand. Once you start using it, the demand increases. Now you need more injection, more medicine. But as you had got it approved, just 1,000, you cannot get more. So that is something we always, with the DRAP or the related department, we can get it approved. At least the bigger hospitals, they can get it approved. But they should be ready to keep the records and to justify the quotas and justify the use, and demands should be not just static. It should be a dynamic sort of demands, and that should be the contract with the departments.
Thank you very much, sir.
Dr. Usman Bashir.
Sir,
सबसे पहले उन्होंने हाथ उठाया था. माइक भी बंद कर दिया इनका.
Thank you very much. I'll try to be brief, but I can very slightly relate to what Ateeq expressed, because he's much more experienced in that context, having worked here and abroad, and what Dr. Jawdat has said. But the role of conferences like this, like you have suggested, that you should come up with some sort of way forward to have solutions, especially for the public sector, because you're privileged to be in Shaukat Khanam, Aga Khan, okay, you have setups, resources available, expertise available. I had a recent privilege of working in a very big organization and leading the department there. And one thing I learned over there from the processes, and what I suggest for you all here as well, that whenever you have to start such a complex process as setting up a pain clinic, it's a very complex process and it will take time. And I learned there that for starting such processes, there is a mechanism like they use. They create a task force, they create a risk and quality department, create certain pathways for you. That's how you will follow this task. You know, of course, we cannot create all that here, but when you have to create such a complex task, at least make a task force from this organization, STSP, who can have some tangible targets, like maybe 1 year target, maybe 2 year target, okay, and break down your components into like failure mode effect analysis, we call it, that you create all your failure modes, that, okay, we don't have a pain clinic, this is a failure. What is the effect analysis? How will we analyze and solve it?
And before we set up our next
targets.
Conference, we need to
create
sit
the time targets,
yes,
and develop a task force. I'm happy to give you the structure for those, because that helped us a lot, Usman will agree, even to create small components of the service. But that taught me a lot, that, okay, that's how you follow a process of opening a service, you know. I didn't know it. I opened a service in National Hospital, but that was all myself, like Khalid Bashir, and everybody has opened themselves. But then you learn by these processes. So this process will take time. Ateeq will agree that 5 years ago, we were talking about the same things. And still we are there. So until you create a task force and start moving in, even in small steps, that will still achieve something, rather than us sitting here again after 5 years and talking about same thing.
So here comes the role of
so
societies.
Yes.
Come forward and please. Thank you so much, audience, for listening to us. And
Can we use heroin for the palliative care users? Pediatric का आप बता दें, adults का मैं बता देता हूँ.
Heroin is like morphine?
Heroin.
Sorry?
Heroin is the... well, officially we cannot, but one of our very affluential patients, his father was a smoker, he got lung cancer, he was in his late 80s, so he went himself to Lyari, and he got him heroin cigarettes, and it's like, आप एक सुबह पिए, एक शाम पिए. So it was patient's decision. वो तो कुछ भी कर सकते हैं. उसने कहा मैं अपने बाप को तड़पता नहीं देख सकता. Well, we as a doctors cannot recommend it. Was that?
Thank you so much, sir.
Maybe the parent.
Thank you for
without
joining
hearing
us.
the word heroin.
So we'll be moving ahead towards our next session. Thank you, Dr. Rabia. Thank you, Professor Asim, Dr. Ateeq, Dr. Taskheer, Ms. Nasira, and thank you, Dr. Agha. Thank you so
And
much.
thank you.